Hello, I'm David McMahon, the CEO of the Irish Skin Foundation. Welcome to everybody. Thank you for joining our first SkinSideOut webinar, which is all about psoriasis. This year, the theme for World Psoriasis Day was being informed. And in the Irish Skin Foundation, we recognize that the majority of care for psoriasis is self-care. We understand that psoriasis is about more than just the skin, and that we have to take a wider look at our overall health as part of taking control of the condition. Today, we're going to hear about the health impacts of psoriasis beyond the skin. We'll discuss some commonly associated conditions, aka co-morbidities, and how we can take steps towards improving our overall health. You'll also hear about some recent Irish study findings, and panelists will answer questions throughout the webinar that we have received from you beforehand, and some that will come in live during the webinar. Joining us today on our panel are Professor Anne-Marie Tobin, Consultant Dermatologist in Tallaght University Hospital and Naas General Hospital; Caroline Irwin, Psoriasis Patient Advocate and founder member of the Irish Skin Foundation; Dr. Catherine Wilkinson, GP at Tallaght Cross and a clinical assistant in dermatology; and lastly, Dr. Cathal O'Connor, who's a dermatology specialist registrar at the Royal College of Physicians of Ireland. Before we kick off though today, I have asked Caroline Irwin if she'd like to say a few words to everybody who's joining us today, just to welcome everybody and to tell us why this webinar is so important. Over to you, Caroline.
Hello, everybody. Thanks for joining us, and hope we can be of some good information and answer your questions. I have suffered from psoriasis over 50 years. I do have several of the comorbidities, which we're going to talk about later. And it's really important that people look after your psoriasis, and I'm so glad we're doing this webinar today, and hopefully we can answer all your questions. Thank you.
Thanks very much, Caroline. That's great. Just before we get into the first presentation, I just want to draw everyone's attention to the chat feature at the bottom of your screen, and you'll be able to. We will be sharing some useful links during the course of the webinar. For as they come up in the presentations, and you might like to click through those or just have a look at them later on. You'll also see at the bottom there is a Q&A feature. So we have about, I think, quite a good number of questions from everybody already. But if you think of any other questions, pop them in there, and hopefully we'll be able to get around to discussing those later on. At the end, what we're going to do today is we're going to have 3 short 10-minute presentations, and there will be questions after each of the presentations. Most of these are going to be questions that we've gotten from you already, and then we will have a panel discussion, and time permitting, an opportunity to discuss any other questions that might come up. I would remind everybody that if we don't get around to answering your question, the Irish Skin Foundation runs an Ask a Nurse helpline, where you can send us in a question through our website, irishskin.ie, anytime. So I think it's time now to ask Professor Tobin and Marie to start us off by giving us an overview of what we're talking about when we discuss, or when we refer to associated conditions or comorbidities of psoriasis. Thanks very much, Anne-Marie.
Thanks very much, David. I just want to make sure that, here we go. So comorbidities, so comorbidities are prevalent in a number of conditions, not only in skin, but also you find this in patients with inflammatory bowel disease, with patients with other skin conditions. And what comorbidity means is that along with having psoriasis, you might also have one of these different conditions. Now, there's a couple of points to make about it. One is, if you have psoriasis, it doesn't mean that you will definitely get one of these conditions. So that's an important thing to keep in mind. And I suppose what we're really keen to do, and why I think it's important that we have this kind of information out there, is that patients are aware of what to look out for, but it doesn't necessarily mean that you are all going to get these conditions. So there's an important thing about comorbidity, though, and psoriasis, and it's slightly different to what you might expect. But in 2014, the World Health Organization recognized psoriasis as a serious non-communicable disease and passed a resolution. And in ways, that's incredibly important for you as patients, because what it meant was that psoriasis went from being this, well, you know what, it's a skin disease, it won't kill you, to suddenly being this condition actually which physicians, which health funders, which health authorities were forced to take much more seriously. So the couple of things in the report, it recognized, one, that certain populations struggle with access to good care for psoriasis, but it also emphasized the importance of getting care for your psoriasis, and also it raised and outlined comorbidities associated with psoriasis. The most prevalent comorbidity in psoriasis is actually nail psoriasis. So you can all look at your nails as you're sitting at your computer. So this is the thing we look out for most in patients who present with plaque psoriasis, and that is, do they have involvement of their nails? And the involvement can be different. It can be pitting. So you can see those little pits. The other thing is you can have lifting off of the nail, off your nail plate, and that's incredibly sore. So if you can see, if you hit that nail off anything, it almost lifts off the whole nail. But nail psoriasis is important, and it's important for two reasons. One, it can be extremely disfiguring. So, for example, I have some patients who are public facing, they're receptionists, and you know, their psoriasis on their skin may not be bad, but they've really severe nail psoriasis, which we are treating because it's a significant impact on their confidence and their self-esteem. But the important thing about nail psoriasis is it's more common in patients who go on to develop the next most common comorbidity, which is psoriatic arthritis. So psoriatic arthritis is where patients with psoriasis begin to develop inflammation, not only in their joints, but also in their tendons. So it's quite different to the other arthritis you'd be familiar with, like rheumatoid. In that, one, there's no good blood test or good marker that you can take and say, oh, you definitely have joint involvement. But it's really important to be aware of the potential involvement, because I couldn't count the number of patients I have who put down their aches and pains. Oh, I thought it was just getting older, or that it was just an aging thing. And this is a nice Irish study that was carried out in St. Vincent's. And what they found was that 30% of patients who were attending a dermatology clinic and who were on treatment for their psoriasis, so they were either receiving medication like methotrexate, or they were receiving a biologic. So in theory, these were getting good treatment. They had undiagnosed psoriatic arthritis. And the important thing to remember is that if you have severe psoriasis, you're more likely to have, one, the nail involvement, two, the joint involvement, and also you're at increased risk of the other comorbidities. And with psoriatic arthritis, it can present, there's 5 different ways it can present, but often it can present in your fingers and toenails. And this is the medical term, dactylitis, but this is the term, you call them sausage fingers, which is much more descriptive, I think, because what you see here is patients lose. If you look at a normal finger, you have a narrowing between each joint. they lose that narrowing and they're the same width the whole way down. But look here, look at the nail involvement. And why we always look for nails is that a lot of rheumatologists consider the nail to be an extension of that little joint at the end of your finger. So we know that if patients have severe nail involvement, they're more likely to have the joint involvement. And what's important to pick up the joint involvement is here is the x-ray of these hands, and you can see that you're getting destruction of the joint, and you want to pick that up early because you want to prevent any joint destruction. The other thing which is slightly unique about psoriatic arthritis is that it can affect tendons. So often patients have things like tennis elbow, or they have pain in their Achilles heel, or they what's known as plantar fasciitis. So, you know, their heels are sore. And that actually is where you can see the tendon. So this is an MRI. You can see where the tendon is inserting into the joint, and that's inflamed. So the one thing that's a good screening for anyone who has psoriasis is if you have sort of ongoing pain in your heel, or if you wake up in the morning and your joints are stiff, if you're getting out of bed like an old person in the morning and it's taking more than 20 minutes before you get going, keep that at the back of your mind and bring it up with your doctor. And usually what happens with psoriatic arthritis, people have the skin manifestations first, and then approximately 10 years later, they begin to develop the joint infections. And again, more common in those patients with more severe skin involvement. The next most common comorbidity or the potential is cardiovascular disease. And this was a really interesting study, which was very much changed how we as physicians, or in general, how the medical community and funders began to look at psoriasis. Because what this study showed, and it was an interesting study because it was carried out in Philadelphia using data from the GP practices in England. And what it showed that if you controlled patients, so if you took patients with psoriasis and patients who didn't have it, with the same risk, with same smoking habits, the same blood pressure, the same having psoriasis, but it was only true for those patients with severe psoriasis, had a slightly increased risk of developing heart disease, so something like a heart attack or a stroke. And again, that was a game changer because in many ways it reinforced that it is terribly important to treat patients who have severe psoriasis so that they are not carrying around a burden of inflammation which may be adversely affecting their joints and adversely affecting their cardiovascular risk. Two other things, because I'm not going to cover comorbidities in great detail because Dr. Wilkinson, Catherine, is going to cover them in more detail. If you have psoriasis, it's worth not hitting the drink, although to be quite honest with you, we're all feeling a little bit like that with COVID, because we know that if you drink excessively, and excessive alcohol is more than 14 units a week for ladies and more than 21 units a week for men, it increases your risk of developing psoriasis and also of developing more severe psoriasis. So just keep an eye on how much alcohol you're consuming. Often patients will say that if they go out and they have a couple of drinks, the following morning they find that their psoriasis is more red and itchy. And in a real killjoy, the same is true for smoking. So smoking is a risk factor for the development of psoriasis, particularly in women and particularly in patients who develop a particular type of psoriasis, which gives you pustules on their hands and feet and can be just very, very painful. And it also, when you smoke, you may not respond as well to certain treatments and you may have more severe disease. So on that cheerful note, that's I'm going to hand over to David.
Thanks very much, Anne-Marie. That's great. Much appreciated. I hope you can all hear me there. Anne-Marie, I have a couple of questions for you. We got in about 10 questions that sort of fall under your presentation. You've kind of covered a certain amount of them already. And I know you mentioned that Catherine is going to deal with some of the other conditions in her own presentation. But one question that came in from one lady. So her question is, if you have mild to moderate psoriasis, are you at the same risk of comorbidities as somebody who has moderate to severe psoriasis?
No, the research says you're not. No, if you've mild to moderate psoriasis, you're at less risk compared to someone with severe or extensive psoriasis.
Okay. And another question that came in actually starts off with scalp psoriasis. So someone here has been diagnosed recently with scalp psoriasis, and she's wondering how long in general is it possible to say how long between then and developing, say, something like psoriatic arthritis or psoriasis itself more beyond the scalp? Is it possible to say that?
Oh, well, the scalp psoriasis is usually the presenting point of psoriasis for most patients, but often people just get scalp psoriasis. It's not a given that you go on to develop full-blown psoriasis. And if you do have scalp psoriasis, again, about 30% of patients will go on to develop the joint involvement, but it occurs about 10 years down the line. So you have a 1 in 3 chance of developing the joint involvement. But again, it's not a given that you will develop either psoriasis or joint involvement.
Okay. And the last question I'm going to ask you is just about links to type 2 diabetes. And as the question puts it, and impacts on related medicines. Okay,
so what's interesting about comorbidities in psoriasis, they were known about for years and years and years. So way back in the late 70s, like people knew that diabetics were more likely to have psoriasis and vice versa. And we don't know, is it chicken or egg? So is it the inflammation that you get from psoriasis makes you more likely to become diabetic, or is it the diabetes? But there's a couple of things we know. We know that if you're overweight, you're more likely to have severe psoriasis. And with regard to medication, there has been a little bit of literature on these new medications called GLP-1 analogs, which help with weight loss, that they can also help with psoriasis. And also, there had been a little bit of old research looking at metformin, which is glucophage, which a lot of people would be on, but it doesn't really translate into actually being a treatment for psoriasis. I think it's two things. If you have extensive psoriasis, you want that well controlled. And if you, in terms of your diabetes risk, and I think the same is true of your diabetes and psoriasis.
Okay. Thank you very much, Anne-Marie, and thank you for your presentation. Just for everybody's benefit out there, we might put up links as well to Diabetes Ireland and Arthritis Ireland, both really good organisations and both excellent for getting information, support, and and other resources about both psoriatic arthritis and diabetes. So just to introduce our next speaker, an Irish study has recently been completed among psoriasis patients in the outpatients department in the University Hospital in Waterford, and it was all about the awareness of psoriasis causes, the exacerbating factors, and the increased risks of developing certain conditions. So we're very lucky today to be joined by the author of that study, Dr. Cathal O'Connor, give us an overview of why University Hospital Waterford undertook the study in the first place, what he learned about levels of awareness from psoriasis patients at the hospital, and the significance of these findings.
Hi everyone, thanks so much for the invitation to speak today. Thanks very much to the Irish Skin Foundation. I'm delighted to present the findings of our study from Waterford, which looked at comorbidity knowledge in patients with psoriasis with moderate to severe disease mostly. So we had 214 patients in our dermatology clinics in Waterford who filled out the questionnaires. We had a very wide range of ages between 17 to 85, with the mean age being 50. And 90% of patients, as you'd expect in a dermatology clinic, had moderate to severe psoriasis and were on systemic or biologic treatments. So this just runs through the patient characteristics. We've discussed some of these in detail, but just of interest, some of the factors which were shown to have higher scores. So a family history of psoriasis was shown to be associated with higher scores. So if parents or brothers and sisters had psoriasis, people had better knowledge. Use of the internet also had quite a significant effect on the knowledge of comorbidities in patients. And then finally, the other area that was shown to be helpful in terms of knowledge for comorbidities was being a member of a patient support group. So they all had important factors. So I might just show this graphically with the next slide, just to run through all the different findings that we had. So we divided up the knowledge parameters into those associated with the cause of psoriasis, associated with things that make psoriasis worse or make psoriasis better, and then other diseases that are associated with psoriasis. So looking at the bottom of the graph here with the dark green and the lighter green numbers, so 74% of people overall had very good knowledge of these parameters. So thankfully, almost 100% of people knew that it wasn't contagious. Approximately 70% of people then knew that it was hereditary, not caused by food allergy, and caused by excessive rapid skin turnover. So overall, people had quite a good understanding of the cause of psoriasis. Moving on then to factors which make psoriasis better or worse. This was a little bit more mixed. So a lot of people knew that stress can precipitate flares of psoriasis or make psoriasis worse, and that's probably because people had experienced this themselves. About 90% of people knew that topical products, so certain creams or lotions, could make psoriasis worse. However, less than half of people knew that some medications, such as antibiotics or other medications, could potentially make psoriasis worse. And that's just an important thing to be aware if someone does have bad psoriasis before they're put on a treatment by another doctor. Only 60% of people knew that infections make psoriasis worse, which I was a little bit surprised at because a lot of people would know the association with throat infections, for example. And 80% of people did know that sun improves psoriasis control. Over 80% of people knew that exercise is good for psoriasis, but less than 60% of people knew that smoking is bad for psoriasis, and less than 70% of people knew that alcohol was bad for psoriasis. Moving up to the top bar, which looks at the comorbidities associated with psoriasis, really the standout features which we were very concerned about were the poor awareness of inflammatory bowel disease, so that's ulcerative colitis and Crohn's disease, although it is a low risk overall in psoriasis, and then ischemic heart disease, which is another word for general heart disease related to problems with blood flow into the heart. So only 12% of patients in the study out of over 200 patients knew that there was a link between psoriasis and inflammatory bowel disease, and only 16%, so only 1 in 6 people knew that there was an increased risk of heart disease with psoriasis, particularly with severe psoriasis. Less than 40% of people knew that hair can be affected, so the hair loss, hair thinning can be a feature. And again, only 37% of people knew that treatment for skin psoriasis reduces their risk of complications from other comorbidities with systemic or biologic treatments, so the tablets or injections. Over 50% of people knew that more organs than the skin are involved, and then better areas, so up to 90% of people knew that psoriasis was associated with depression and arthritis, and almost 80% of people knew that nail involvement was a key feature of psoriasis. So in terms of how people rated their own knowledge, generally people were quite comfortable with what they thought they knew. So 73% of people reported themselves as being quite well informed regarding treatments for psoriasis, and only 10% were not at all informed, and 17% felt very well informed. In terms of comorbidities, only 53%, however, reported being quite well informed, 40% were not at all informed, and 7% did feel very well informed. And just importantly, almost 90% of patients reported that their family doctor was a key source of information about psoriasis. So it's really important that patients are aware of these risks so that other modifiable risk factors can be optimally managed with our colleagues in primary care, our GP colleagues. The risk of heart disease can be reduced by increasing physical activity, improving diet and nutrition, and optimizing cholesterol levels. And we now have really effective targeted medicines for psoriasis that, as Prof Tobin has said, that also reduce the risk of heart disease and can treat associated diseases like bowel and joint problems. And it's really important for us to highlight this knowledge gap, particularly the gap with heart disease knowledge, to other dermatologists, GPs and patients, because we'll hopefully improve clinical outcomes by improving this knowledge. And in University Hospital Waterford, there's a plan to repeat the study in 12 months following a kind of an intensive education program. So thanks very much for listening.
That's great. Thank you very much, Cathal. And actually, just as you mentioned there, the educational program that you're going to run in the hospital soon, do you know what that will involve yet, or what kind of things will you cover in that program?
Yeah, so I suppose we have a few features built into the clinic appointments, and things have changed a little bit with COVID, and that we're much more limited in terms of face-to-face contacts. So in terms of the virtual appointments now, we have less opportunity, I suppose, to interact with patients. Whereas in the waiting room, when people are coming for face-to-face contacts, we do have a lot of information available. There are posters up. The Irish Skin Foundation has a very good booklet on psoriasis, and there's quite a lot about comorbidities in that. But when the patient is speaking to the doctor as part of their biologic review, or general psoriasis view, if they're not on one of those agents, it is mentioned, and we do check cholesterol levels once a year, for example, and we just try to highlight the importance of the other practices.
Okay. Do you have any? I mean, based on this study is the first time probably for Ireland that we have any data giving us these kinds of insights. Do you have any opinion, or is there any way of judging how well we are doing compared to other countries?
Yeah, I suppose other countries have looked at it. So it's been looked at in Italy and Norway in particular, and actually the trends were quite similar. So poor awareness of the heart risk. Inflammatory bowel disease hasn't been mentioned so much in the Italian study. It was looked at. But it actually does correlate quite closely with other European studies, but studies actually about the knowledge of patients with psoriasis about comorbidities is quite limited in general.
Okay. Thank you very much, Cathal. That was very interesting, and really nice to have an opportunity to see a snapshot of what it's like actually in Ireland, and go through an Irish study. So thank you. This brings us to our last speaker, Dr. Catherine Wilkinson, and actually this is, I suppose, ties in kind of quite well with Dr. O'Connor's research, in that he indicated how important GPs are for making sure that people have the right information and as the first points of contact, really, beyond maybe their family, about psoriasis. So Catherine is going to talk about, I suppose, comorbidities as well, but also specifically about how services are operating during the COVID-19 pandemic. And of course, as usual, the GPs are on the front line in dealing with all of that. Thanks very much, Catherine. If you'd like to begin your talk.
Thanks, David. So I thought it'd be good to start by just giving some tips on accessing GP services during COVID. It's important to stress the fact that GP practices were all open. We're still providing the same services during COVID as what we were before COVID, but it's just that we're providing them in a different way. So if you want to make an appointment with your GP, you need to ring rather than walking into the GP practice. And I suppose the reason for that is that we want to control numbers in our waiting room so as to ensure appropriate social distancing and to keep our waiting rooms safe for our patients. So when you ring up, you'll speak to your receptionist, and they may ask you just a brief summary of why you wish to speak to your GP. And don't worry, this is all confidential. And even if you just give a one-line summary of why you want to speak to your GP, it will just help the GP practice manage your queries a lot more efficiently. So it might just be, listen, if you're having joint pains, like what Dr. Tobin was mentioning, you might just say, listen, I've got joint pains and I have psoriasis. I'm worried about arthritis. Can I please speak with the GP about it? Now we are doing both face-to-face and telephone consultations in the GP practice. We are sorting out a lot over the phone, but certainly I'm seeing an awful lot of patients face-to-face. And if you feel like you would prefer to have a face-to-face consultation, it's very reasonable to just request that. And don't be afraid to request it. And you can mention it to the receptionist that this would be your preference, or when you're speaking to your GP, feel free to say to them as well too, okay? So in 2013, the European Society of Cardiology, they issued a statement, a paper, just outlining the fact that psoriasis patients should be screened for cardiovascular disease. So today I'm just going to talk about a bit about, well, what does screening mean? What does screening mean? When should you get it done? When should you start presenting to your GP for screening? And then how often should you reattend? So cardiovascular screening would consist of getting a blood pressure check, because we do know that high blood pressure is more common amongst patients with psoriasis. And patients with psoriasis, if they do have high blood pressure, they may need a few tablets to control it. So don't be disheartened if you do have high blood pressure and it does require multiple tablets. You're not alone. This is to be expected. So you might initially start off by having a once-off blood pressure check, and then depending on that result, your GP might recommend that you go for a 24-hour blood pressure monitor, which gives us a lot more information than a once-off blood pressure reading. And certainly we would rarely start a blood pressure medication on somebody based on one reading. Our preference is for the 24-hour monitor. And in the last few years, thankfully, blood pressure monitors have been made freely available to patients with medical cards, whereas before patients with medical cards would have had to pay for it. Also, you can request to have your heart rhythm checked. It may not be automatically involve a part of screening, but it's something that I think is quite a good thing to request. We like for everyone's heart rhythm to be regular, so we just want to make sure that it is regular. If it is irregular, it doesn't mean that there's a problem, but it would prompt your GP to further investigate. You would also attend for fasting blood tests, because we do know, as Dr. Tobin mentioned, that diabetes is more prevalent amongst patients with psoriasis, as is high cholesterol. As part of these tests, we would also do liver function tests, kidney tests, and an anemia check. It would just be done routinely in conjunction with them. You could also request a BMI check, and I think this would be good. This takes into account your height and weight. We do know, while being overweight hasn't been, we've no proof to say that this causes psoriasis. Being overweight, it is more likely to occur amongst patients who have psoriasis, and certainly that would increase your heart risk as well. So it's good to have an awareness of, well, where does my BMI lie in the chart? And it's important to attend for screening even if you feel well, because if you have high blood pressure or diabetes or raised cholesterol, these are often silent and you may not have any symptoms. So just because you feel well doesn't mean that you don't attend for screening or that you may not have an underlying problem. So I suppose you might be asking, well, when should I attend to my GP for screening, and how frequently then should I reattend? There's no clear consensus or guideline on this. So because of this, I rang my local friendly cardiologist in Tallaght Hospital, who recommended that he felt that a good rule of thumb was that someone would start at the age of 35, and he suggested that people attend annually. Now, depending on your own situation, your GP may modify this approach. Like, for example, if you're normal BMI, you're a non-smoker, your cholesterol is good, your blood pressure is controlled, your GP might tell you, listen, you don't need to repeat these for another 2 years. And I think that's very reasonable. So I'm going to focus more on dietary and lifestyle approaches, which you could adopt that will help prevent you from developing these problems and the complications associated with them. I'm not going to spend too much time talking about medication treatment of these conditions, but I felt, I thought it'd be good to just empower you with knowledge about how you can take control of your situation. So losing even a small amount of weight, if you're overweight, can help reduce your blood pressure, and it can help reduce your risk of heart attack and stroke. So even like a 5% reduction in your weight can really have positive benefits for you. Exercise is recommended. 150 minutes, if you can space that out throughout the week. And for example, just brisk walking, that would be great, even just to briskly walk. And I suppose someone might ask, you might be thinking, well, what does brisk walking mean? So if you're able to talk while walking, but you wouldn't be able to sing, that would be the test for if you're walking briskly. Eating healthily, and I'll mention a good, I'll direct you towards a good website that will give you plenty of information regarding that. Reducing your salt intake, and this is especially important for reducing your blood pressure. So avoid adding salt to your food, using herbs or spices, and looking at food labels. And I'm going to talk a bit about that in the next few slides. Quit smoking, as Dr. Tobin mentioned, smoking is a risk factor for the onset of psoriasis, and it is a risk factor for increased severity of psoriasis. It also increases your risk of heart attack and stroke, and it increases your blood pressure. So if you can, it would be brilliant if you could stop smoking. To limit your alcohol intake, we do know that drinking more than moderate amounts of alcohol can actually raise your blood pressure. It can increase your cholesterol, and it can increase your sugar levels while also increasing your weight. So, and it can also reduce the effectiveness of blood pressure medications. So if you could reduce it, that would be great. And listen, I know in an ideal world wouldn't be great if we were all stress-free, but if you could try to reduce stress where possible. So safefood.net, it's an excellent website. It's an Irish website, and it gives loads of great information on how to eat healthily, examples of recipes, and of it also teaches you as well how to read food labels, which I'm going to talk a bit more about. So I'd really recommend checking this out. So there is, you may have noticed on some of the food items in your house that there is a traffic light system for food labeling. So as you can see here on the screen, the fat and saturates on that food label is in the green. So it's good from that point of view. It's quite high in sugar, and it's got a medium amount of salt. So if you've got high blood pressure, ideally you'd like your salt to be in the green. And every now and again, you could have a food with salt that's in the amber or the orange color. So green is the best choice. Amber color, okay, most of the time, and red, really only occasionally should you eat that. Now, not every food labels use this traffic light system approach. So it is good if you do have high blood pressure, or if you do want to lose weight, it is good to be aware of, well, what are the normal ranges? So this is a food label from a packet of processed ham. And as you can see here, the salt level is 1.6 grams per 100 grams, which is greater than 1.5 per 100 grams, which would actually put this food into the red for salt. And that would be consistent with the recommendations to avoid processed meats like ham and sausages, because they are high in salt and they will worsen your blood pressure as a result. So an awareness of all this, I think it would definitely be good. And safefood.net has got all this information. As I mentioned, quit smoking, if you look up quit.ie, it's got great information that can help you do that. And it also gives information on nicotine replacement therapy and the support services that are available nationally that can assist you with this. Nicotine replacement therapy will double your chances of quitting smoking. And certainly we know that nicotine replacement therapy and tablets like Champix will, definitely increase your chances versus just trying it alone. So nicotine replacement therapy comes in various forms, and there's no one form that's better than another. It's about which form suits you. So patches, gum, lozenges, inhalers, mouth sprays. You can buy the nicotine replacement therapy over the counter. But if you have a medical card, ask your GP for a prescription for them, because you can get them on the medical card. Also, Champix is a 3-month course of tablets, which are not available over the counter. Your GP would have to prescribe it. So if you have failed nicotine replacement therapy, well, the next step would be Champix. So discuss that with your GP, and it's definitely worth trying. So drinkaware.ie, it's actually a really informative website. So if you were a bit concerned about your drinking, or even if you were just curious about, well, how does my intake rate compared to what the guidelines state, I would recommend you just go on this website. There's a drinks calculator there, so which you can easily put in your intake over the last week and see where you are. So for example, a half bottle of wine is 4 standard drinks. And then if you want to see, well, how does that compare to the guidelines? It also tells you what the guidelines are. So a woman should be drinking less than 11 standard drinks per week with 2 free alcohol days, while a man should drink less than 17 standard drinks. And the reason for the 2 alcohol-free days is so as to reduce your risk of developing a habit of excess or hazardous drinking, and also better for your mental health. If you are concerned about your drinking and you're wondering, well, where do I go next? Obviously, you can go to your GP, but on that website, there is actually quite a number of services listed that you could phone. I'd also, for anybody who has who has high blood pressure, or who has a history of heart attack or stroke or diabetes, or is on immunosuppressants for their psoriasis, it is really important to attend for your flu vaccine annually, and also to obtain the pneumonia vaccine, which is to be administered once before the age of 65, once over the age of 65, with an interval of 5 years between administrations. Also, if you have children between the age of 2 and 12, or indeed grandchildren, encourage them to go to their GP or local pharmacist for their free flu vaccine. It's just a nose spray. It's really well tolerated, and children, they're more likely to get influenza than to get COVID. They're more likely to get sick with influenza than COVID, and they're certainly more likely to transmit influenza. So you don't want to be getting influenza from your child or your grandchild. So it's very important to look after your mental health, because looking after your mental health helps your physical health. So I think a good first port of call here is on the Irish Skin Foundation website. And if you can look at the Inside Out campaign, or Ask How I Feel campaign, and you'll be able to watch videos between Eddie Murphy, our psychologist, and Caroline. And certainly just hearing somebody else's story and knowing you're not alone can definitely improve your mental health. Also, mindfulness and cognitive behavioral therapy. There's psychological interventions that have been shown to improve psoriasis and your mental health. These can be accessed freely online or via a psychologist. Beaumont Hospital have a lovely website and a relaxation center, which I would recommend you visiting, and you can access mindfulness resources there via that website. Also, if you're feeling, I mean, they're all good things to start off with, but if you are feeling a bit overwhelmed, you ring your GP and you ask to speak with your GP about how you're feeling, and make your mental health the focus of the consultation. Sorry, my light has gone here. Make your mental health the focus of your consultation. Don't bring it up at the end of the consultation. If you know your GP well, you might be happy to talk about your mental health with your GP over the phone. But if you don't know the person you're talking to, you might prefer to meet them face to face. And it's very reasonable to request a face-to-face consultation, and I would encourage you to do so. So takeaway points, this is my last slide. So high blood pressure, cholesterol and diabetes, these things can all be made better and controlled with lifestyle changes plus or minus medications. It's important to take all your medications daily. Most medications are prescribed daily and they'll only stay in your system for 24 hours. So like, for example, high blood pressure, it's not like treating a chest infection where you complete your course of antibiotics and your infection is cured. Most likely, if you go on blood pressure tablets, it's most likely going to be for the rest of your life, okay? Unless you can do drastic lifestyle changes like losing a lot of weight or quitting alcohol. But for most people, it is a lifelong thing. Even small changes in your lifestyle can significantly improve your health. So don't underestimate the importance of small changes. If you do have health concerns, discuss it with your pharmacist or your GP practice nurse or your GP. GP practices, they're all open and safe to attend, and get the flu vaccine. So thanks very much.
Thanks very much, Catherine. I thought I was going to ask you about, which you've covered really, about kind of people trying to bite off more than they can chew, because there's so many different things that you can do there. And I suppose if you're in a pattern of bad habits, if you're smoking and you don't want to be smoking, if you're drinking too much, you don't want to be drinking as much, and maybe you're not exercising and it's dark and it's been a really bad year. Like, it sounds like an awful lot of stress even thinking about, God, I have to get myself in order. Like, is there anything we can kind of say to people that just gives everybody a bit of reassurance that that's okay too, that we don't have to nail ourselves to the cross about that?
Yeah, well, definitely important, especially now, to be nice to yourself. Well, it's always important to be nice to yourself. And really, if you feel there's multiple areas that you need to work on, I would definitely not be taking on all of them. I would pick one. I'd pick the one that you feel most able to tackle, most motivated to tackle, and I would take that. And listen, any improvements in that area, you need to congratulate yourself and be nice to yourself. And then with that kind of positive approach to yourself, it will definitely improve your success at tackling the other things.
Yeah, and it was great now to get so many different websites that you've shared throughout that. I think all of those have gone up in chat, so people can have a look at them. And I suppose I'd encourage people to try to kind of stick to the good websites, because there's not all information is kind of equal. And with that in mind, like, we got a lot of questions in about diet, right? So like, not just about not questions like, what do I say to a dietitian, but questions like, what can I give up that will make my psoriasis better, or what food really enrage was actually the word, enrage my psoriasis, a great word. Like,
can I come in there, David, because there's an awful lot of misinformation about there that diet is related to psoriasis. It's not in any way. So cutting out a particular food, or cutting out tomatoes, or cutting out vinegar, or whatever, it does not impact your psoriasis. The only thing we know regarding diet is if you're overweight or obese, you're more likely to have severe psoriasis. But diet is not, it's not, and there's a lot out on the internet regarding that, but it is not related to psoriasis. Caroline probably wants to come in on that.
Yeah, I mean, for years I didn't think anything made a difference, but not to disagree with you, but I do found over the years, when I would eat yeast bread, or a lot of bread with yeast in it, it would certainly pink up and flare. I think there's certain foodstuffs can cause flares. They're not going to cure your psoriasis by giving them up, but I do think it stopped me flaring as much. I'd eat more brown bread without yeast in it. And probably dairy, cheese sometimes, but that's just with me. That's what I find, it would cause less flares.
I think what you might actually be finding, Caroline, is that bread pushes up your glucose levels. So in ways, it's to do with kind of the link between type 2 diabetes and psoriasis. And in that, what you're describing is that, so that's probably correct.
Yeah, there's not enough research has been done about food related, because I mean, we can say that alcohol flares it, so I don't see why we can't say certain things.
Well,
Don't flare it either,
yeah,
but there's no proof, I suppose, or research done.
Well, they know now that alcohol produces a molecule in your skin which actually causes your cells to turn over. So that was research done about 2 years ago from Newcastle or Leeds. They know why alcohol, it actually produces an inflammatory molecule. But what I would say to patients is don't get hung up on diet because you can drive yourself around crazy, and instead focus on something positive like getting a 30-minute walk every day.
Okay, thank you very much, Anne-Marie. I suppose that brings us to kind of the end of the 3 presentations, and we have. I'm kind of mindful that we're coming up on 5 o'clock, so we have a little bit of time. Just to have a discussion among the four of you there. I suppose, you know, like, it was interesting just to cover quickly about, you know, COVID-19. We heard from Catherine there just about, you know, requesting in-person appointments if you want them, and that's really good to know, because you kind of feel you can't maybe ask for that. And in relation to hospitals, like Anne-Marie, you know, how are you seeing services impacted by COVID-19 and waiting times and all that? And what are your expectations over the next year? You look that far.
We can. I'm telling you, the vaccine is coming and Christmas is coming, so hang in there. So with regard to access, we kept all our patients on treatments for psoriasis, largely doing virtual consultations, like either telephone by and large, or the odd tele or video consultation. And then anyone we thought was in trouble at all, we brought them in. So, and I just want to make a comment on that. When COVID first started, we were quite concerned that patients who were on medications for psoriasis might do worse than patients who weren't on. So, for example, if you were on methotrexate or a biologic. And actually what we've seen is that, one, you're at the very same risk of picking it up as everyone else. And the fear that you'd have a worse outcome than someone else hasn't actually borne out. In fact, what seems to be the main driver of the risk is actually the cardiovascular risks, or like having high blood pressure or diabetes. So now we keep patients going on all their medications, and that's come in from large studies now worldwide. With regards to access, so over a 3-month period, most departments, like, their access was definitely reduced by about 70%. When you look at it, by the end of October, almost all departments are back up to 100%. And they're between the impact of COVID has added about 5,000 patients onto the waiting list nationally. So it hasn't been as bad as we thought. As for what I would be keen to say to anyone from this webinar is, if you have severe psoriasis, don't sit in it. Go and get it treated. One, there's fantastic treatments out there. And not only for your skin, your heart deserves it, your joints deserve it, you know, your whole mental health deserves it.
Thanks very much, Anne-Marie. That's great to know. Like, I know as well, you know, I've been talking to people who just they went to hospitals, and they just, I suppose, they were presented with a sort of an unfamiliar vista, in that you can't just walk in like you normally do. It's not the same kind of routine when you go in the door, or you can't get in the door in the same way as you used to. So, you know, a lot of people, I don't think, maybe expect some of these small little things that we're doing all over the place to be happening in hospitals as well, until they actually get there. I suppose that those measures are going to continue until everybody's on everybody has had the vaccine, I guess.
Yes, and Catherine and I were just discussing this before we came on the note of the vaccine. So patients with psoriasis who would be on an immunosuppressant, so they would fall into one of the sort of priority categories to receive the vaccine, and that's important for patients to know as well.
Okay, thank you. And Caroline, just you've had psoriasis for over 50 years, and you went on to be diagnosed with type 2 diabetes, like subsequently. And you're not a stranger to Waterford either. You're living at Kilkenny. What did you think of Cathal's research conducted in Waterford?
Yeah, very interesting. Not surprised with the outcome of the lack of knowledge from people. I've spoken to thousands of people over the last few years, and the amount of people wouldn't have a clue that they were more liable to possibly get diabetes or the psoriatic arthritis. I would say I've met probably 10% of people that might have some knowledge of it and the rest none. I'd meet people saying I got diabetes, and I'd say, well, that's linked, or I'd be trying to warn people to keep your skin treated, get the proper treatments available, and you have less chance of developing it. It's great to see any Irish research, because I used to go back and forth to the English Association for advice, or and the amount of research they'd have done over the years. So, it's great to see. I'm delighted to see some Irish research being done, and hopefully, and also the importance of that information getting to GPs, because, as I said, it's the first protocol for everybody with psoriasis. A lot of people will never see a dermatologist, but GPs need to be able to not just scaremonger people, but to make them aware of this is a possibility for them. So it was great to see that research been done.
Thank you. And Cathal, like if we were going to try to translate some of the findings from your research into action, throughout the country, what would you have would you focus, or what focus would you choose for, say, an organization like the Irish Skin Foundation to concentrate on, with a view to helping people with psoriasis better, more?
Well, you're doing a great job. With the webinar today, it was a really good opportunity for people to learn a bit more about it. The psoriasis book from the Irish Skin Foundation is also very good and very informative. It's very thorough in terms of the extra comorbidities and everything like that. But I think it's probably more a grassroots approach in terms of looking at undergraduate medicine, I think, and nursing, and other healthcare professionals like speech and language therapists or occupational therapists, because psoriasis is quite a visible disease. If people are coming in for other issues into hospital, it's kind of useful, I think, for other specialties or other professions to be aware of the whole paradigm of psoriasis, and know that it's not just a skin disease, that it's affecting, it's a general inflammatory systemic disease. So I think it's just important to highlight it. Probably to healthcare professionals is probably the way to go, because with COVID, we've seen that people can only accept a very limited amount of information without things becoming skewed in terms of people's ability to retain it. We've seen that with the misinformation and things like that. So we probably just need to focus our efforts on the people who are going to be most useful in propagating the beneficial information and screening appropriately for the comorbidities, and not, as we said, scary people.
Yeah. And Catherine, would you like to come in at the end of that, and just maybe just from the GP's perspective, following on from what Cathal says?
Yeah, well, I think definitely undergraduate teaching. I mean, I think that's a really good place to start in educating future doctors about the cardiovascular risk that psoriasis, that is attached with psoriasis. And certainly I teach undergraduates, and I definitely highlight that. From the GP perspective, that information leaflet from the Irish Skin Foundation, I frequently am recommending that to patients to help empower them with the knowledge that they need to help them to take control of their cardiovascular risk. But certainly we need to keep thinking about how can we improve general awareness of this amongst clinicians, and about how, and highlighting the importance of just informing our patients of their need to improve their cardiovascular risk factors.
Okay, thank you very much. And I'm going to end with just two sort of small questions, or maybe they're larger questions, just about psoriasis management that we've just gotten in. One of them, they're kind of related to each other. One of them is really around winter and psoriasis, and is it different managing psoriasis in the winter than it is at another time of the year? And related to that, can psoriasis affect your lips? And is there anything you can do about that?
So with regard to the winter, often patients, and Caroline could actually speak to this, often patients find the winter harder because the sun will help clear up certain patches of psoriasis and your skin dries out as central heating goes on. So it can become more scaly. One of the things, no matter what treatment you're on for your psoriasis, is just to moisturize, because that reduces the flakiness, and it also prevents the skin from drying out and cracking. With regard to, yes, you can get psoriasis on your lips, and if it's bad enough, I would often give a topical steroid for it. You can get a cheilitis or an inflammation of the lips with it. But Caroline would know more about the winter psoriasis.
Yeah, I'd find that I always found the winter, number one, you knew what was coming ahead, the dark days and the bad weather, and as you say, the central heating is on, and we wear warmer clothes. I would have always tried to wear cotton against my skin as much as possible. Moisturizing, yeah, is very important as well. And in the sunshine, we feel better, number one, and brighter days. And the sun does help the majority of people, not everybody with psoriasis, but you just feel better. And it is depressing anyway in the winter.
Okay, thank you very much. And just before we finish up and we sign off, would anybody from the panel like to say any closing words to everybody here today?
Can I just come in and just say, I think it's a positive news story for if you have psoriasis, not to be afraid, because there's fantastic treatments available for psoriasis. And don't be fobbed off, or make sure you get that treatment. I don't know if Caroline would.
Yeah, I'd like to say to people, I'm 50 years on, I was 30 years having psoriasis and never knew anything about diabetes, arthritis, ignored it, made sure it's just a skin problem, got covered from head to toe. And, you know, I don't want people to go through what I did. And I think if people, there's, as you say, fantastic treatments available. People are a bit nervous still about biologics, think they're steroid injections, and there's a lot of misinformation there. But there is no reason to suffer and people to ignore it, because I have type 2 diabetes, I have the arthritis, and I hope I don't get the heart disease, but I need to lose some weight. I'm obese as well. So I think the intervention, early intervention, if you're not getting what you need by creams or whatever, go see a dermatologist. I always say to people, if you had a foot problem, you're not going to go to a brain surgeon, you know what I mean? So go to the proper people that have the treatments available, and just look after your skin, really.
Yeah, and I just want to echo what Anne-Marie and Caroline were just saying there. So if the creams aren't working, because your GP can prescribe you the creams, but we can't, sorry, my light keeps on going off. The GP can prescribe your creams, but the GP can't prescribe the biologics that work so well, and the methotrexate. So if the creams aren't working and you're distressed with your psoriasis, you can just ask your GP for a referral to a local dermatologist. So you don't have to wait for someone to suggest it to you. You can request it.
That's great. Thank you very much. Actually, we have two short questions that have just come in at the end. One is about coal tar based topical products for treatment of psoriasis. With you know, and I think this for this person, they're not working. Any comment on that from maybe Anne-Marie?
So coal tar is one of those ones. I think it either works or it doesn't. And some people find it good, but if it's not working, just stop it. And if your psoriasis is extensive enough, and make sure and go back to your GP. In other people, coal tar works really, really well. And there's no steroid in coal tar, so you can use it on an ongoing basis. But if it's not working, stop.
Okay, and the last question then is just about psoriatic arthritis. Can you just have psoriatic arthritis on its own?
Yeah.
With just a bit of psoriasis in your nail and scalp, so you can. Okay.
Absolutely, yeah. And actually, it's just helpful if you have that little bit of psoriasis in your scalp or nails, because it leads the rheumatologist it's the clue the rheumatologist needs to diagnose psoriatic arthritis, because a lot of people are undiagnosed with psoriatic arthritis because it can be difficult to diagnose.
Okay, okay. Thank you very much. And thank you very much to all of our speakers. I really appreciate you taking time out of your busy schedules today to join us. And to everybody else, thank you for your time, and thank you for tuning in. And please feel free to get in touch with the Irish Skin Foundation or the Irish Skin Foundation's helpline through irishskin.ie if you need any support, or if you have any questions to put to us, or you just want to find out a little bit more about psoriasis. Thank you very much. Bye-bye.